Hey everyone, we're going to get started in just a few minutes. Good evening, everyone. Welcome to our bariatric webinar. We have lots of good information for you tonight on the chronic disease of obesity, its effects on the body, and some treatment options here at TMH. My name is Angie Bunkley. I'm our bariatric surgery program coordinator. Tonight with me, I have Mr. Greg Laffitte. He's one of our bariatric PAs. We also have Dr. Joey Jarrard. He is our medical director for our program. Feel free to utilize the Q&A box if you have any questions. We're going to set aside plenty of time to go over each and every question. Also, those of you that have joined us tonight will be entered into a drawing for a chance to win a Publix gift card, and I will reach out to you via email at the end. With that being said, I want to go ahead and let Mr. Greg get started.
Okay, thank you very much, Angie, for the handoff. Good evening, everybody. I can't think of a better place to be on what appears to be an extremely cold night that's going to put us, I guess, around 27 at 4 or 5 in the morning. Exciting evening here for you. We're going to cover a lot of information, but I want to first and foremost say a stat of what just came across my desk just this past week. I had a lady that was 35 years of age. She's now down 97 pounds. I had a lady that was 40 years of age. She's down 75 pounds. Another woman, 62 years of age. She's down 100 pounds. And I've got a young guy that came in age 46. He's down 82. That's just the few that I was able to write down that I saw just this week. The numbers are absolutely amazing. And I think that you are certainly in for a nice surprise tonight. So let's get into it. A lot of information that I'm going to cover. I'm only going to hit on the parts and the pieces that are important. I'm not going to add fluff. I'm not going to waste your time. But I want to speak about the terminology of the pieces involved with who takes care of us. We've got a team, and that team is important. It's essentially a one-stop shop. You come over and you go through the front door, and the services that you're going to need are going to be able to be accomplished I think quite conveniently. I'm going to go into the definitions about obesity, of the terminology, what that truly means. Sometimes there's some confusion with that. We'll shred out the truth. A big thing is daily challenges. Spend a lot of time talking about that. There's a cost, of course, there and options, and the surgeon's going to go way into the detail about the surgical ins and outs. So let's jump into this, because this is extremely meaningful. When you come to our clinic, you're going to deal with a staff that specializes in obesity and the obesity diseases. Now, why is that important? That's because we do this full time. That's a 24/7, if you will, 365-day focus. This is not something that we do part time. And we do the analysis. We go into your medical file and we give you either surgical or non-surgical, perhaps a medical weight loss opportunity. And we look at the needs of you, the patient, and it's not a one size fits all. We are not a medical weight loss clinic. Out on Mahan Drive, there's a place, I was over there this evening near Bass Pro Shop. It's in between an Indian restaurant and a massage parlor where you can go in and someone will do an EKG on you and they'll write you or even give you a script for phentermine. That's not what we do here. We manage the disease obesity, and there is a dramatic difference for that. And we do a good job. Again, these numbers I gave you just a few seconds ago, that's just this 1 week, and I made it a point to bring those tonight. The term bariatric physician terms, when you hear about bariatrician, that means somebody that professionally spends their time in their craft is to help people to lose this weight. A little bit more about this. I think it's important that you realize when you come and you see us, that is our primary focus. You've got a primary care physician. You may have an orthopedist. You may have a cardiologist. Your internal medicine physician. There's a variety of people that may have referred you to our office for us to specialize in the talents that we have to be able to accomplish this. So there's a big team that's involved. Here in the office, we've got, well, there's myself, of course, and there's Brandy Thompson. And we're engaged, again, solely, fully dedicated to honing our craft to be able to help you get your weight off. The lifestyle piece that goes with it, I don't think it goes without saying that if we're going to have a gastric surgery, we will need to address lifestyle changes. Some of you will tell us when you come in and see us that you've got good habits, that you're making good choices, but no matter what you do, you've not been able to have any meaningful, successful, sustainable weight loss over a period of, say, year two, so on. In our team as well, we've got an exercise physiologist. And if you come up with the question of, well, I'd like to exercise, but I don't know where to begin, we have that resource, and that's Christine to the top left of your screen. And one of our dietitians, very, very smart people, extremely competent and quite compassionate. Patients love talking with her. And there's Brandy again. She's also a registered dietitian. It's exceptional to be able, in today's medical delivery system, to go to one place and to be able to achieve so many things without the hassle of having to go to this place, drive across town, go somewhere else. We're unique, I think, in that case. And it certainly pays out as an advantage and produces big dividends for you guys. The surgical team, Dr. Jarrard, and he'll be on here just a few minutes after I will be completing. There's Dr. James Parker. Megan Bell's the PA with Dr. Jarrard. And there's Courtney over there. She's the PA with Dr. Parker. A fine staff, very, very diligent. And what's really important about this is if you make a call and you have a question, you're going to get a call back. You're going to get an answer. The program does not exist without the superb results that we have without Angie. She was talking with you on the phone, or rather the Wi-Fi here, the way we're doing this call. But she provides a lot of the oversight to it, and you would more than likely get a chance to meet her somewhere through the process. And there's Sam over there. A lot of data is extremely important so that we can measure the success or the areas that perhaps need to use, what could we do better? So our craft is quite dependent upon a team, from program administration all the way up to the surgeons. The The team that you're going to get to work with can accomplish some very, very, very specific things. Let's take a moment and focus on that one. And I would ask you, in your household, wherever you are, if you've got some family members, bring them. Now's a good time to let them sit down here and watch and hear what we're going to discuss. And I would even invite you to get a pencil out or maybe a pen, and let's start taking a look at some of the details that you would be encountering in order to be one of these people that's lost 97, 75, 100, or 82 pounds. As just a pause on this, bariatric surgery, and I don't think I'm going to steal the thunder from the surgeon, but bariatric surgery is demonstrated across the board to be able to produce results far greater than many of these other, what we would call in vogue approaches right now, the injectable medications. The surgery 9 times out of 10 is going to trump the outcome that you had hoped for. You would be able to, I think, see it and recognize it, and be able then to have the support for you to be able to reach your long-term goal. Okay, top of the page, evaluate the metabolic and medical causes. Again, I don't dedicate my profession to just losing weight. That's not the part. The part that's extremely important is to defeat this disease that's obesity. And I had a young gal that came in this afternoon, and she says, I've been fighting this since I was 5 years old. My dad used to give me a hard time about it. My mom took me to Weight Watchers. I was very conscientious or self-conscious about it, if you will. It just shaped how she viewed herself through all of these years. And so we take into consideration that there might even be some eating disorders that have been developed because of an upbringing. So I'm looking at, with lab results, I'm looking at maybe a medication that you might take. There might even be a circumstance through some blood work that we provide you to try to get an analysis with this. I want to know, well, she's got obesity. When did it start? What's been done thus far? What's the success look like? Where's an area that we can work with? Lab work's extremely important. The lab work's going to help us maybe find out something that you didn't know existed. And if there's a deficiency, then that gives us the evidence-based skill set to make some changes. Behavior modifications are really, really huge. If you went back into, say, the 1700s, if you were in the 1700s and you were on a wagon going westward ho, you did not have a fast food place on every corner. Amazon couldn't deliver you this, or you name it. We live in a different world now compared to then. And so the behavior that we have with today's environment sometimes contributes in a very negative way to overeating, overindulgence, indiscretion, making poor choices. And quite frankly, ladies and gentlemen, over a given span of time, that weight can come on board. So the bariatric team is very much invested in not turning a blind eye to your health. We want to face this head on and help you to make nutritional changes, improve the intake, improve the habits. And it's not to shame you, it's not to scold you, but it's to say, hey, we understand, we appreciate where you've been, and we're the ones with the corporate knowledge to help you go down this pathway to get the success that you would hope for. Again, third time I've said this. 1, 2, 3, 4 people that have come in just in this past week, one down 97 pounds, 75, 182. And I've been doing this for quite some time. I've seen people that have lost as much as 200. We hope, and this is not just a false statement or it's easy to say it, but we want to optimize that physical health to support your long-term surgical success. What you're doing today, what you're doing tonight, listening to this presentation and hopefully taking some notes, and based upon what your current age, this is going to have a lot to do and dictate what your health looks like when you're in your, say, 60s, 70s, and maybe into the 80s. And if you think about that, what could you do today to make sure that you got to be around and be independent and not living in a nursing home, not confined to a wheelchair, not having to go to dialysis? What about 2 pages of medications? What about the business of living in a place where people don't come to visit, and on and so forth? So optimize physical health to support surgical success. That's what we get paid to do. And I don't mind saying it. We're good at it. And I would welcome you to come on board and let us help you out with this. Now, this team that we have, I see these folks every day. Get there in the morning. I'm generally there by about 6:45 and generally there by 16:30, 5 o'clock in the afternoon. So we talk, we go back and forth. Hey, what about this person? What about that? There's a lot of discussion that goes back and forth, and we begin to know you. Now, what do you get out of that? You also get to know us, and that helps you stay accountable. You're going to get the support not only from me, but from Brandy, from the dietitian, across the spectrum of our staff. And I've got some fantastic gals that work down at the table. Our nurse, Amy, we've got Connie, very, very conscientious people. And we're trying to bring all of these talents together so that we can optimize what the outcome is going to look like. Think about this. How do we make sure that you understand about nutritional choices? Well, we've got a dietitian that's very skilled with a master's level. This isn't just getting on the internet and asking Grok, well, what do I do about that? No, you're going to go one-on-one with someone. You're going to exchange the information based on the experience that you share to come up with a plan. And we're going to do that before, and we're also going to do it after the surgery. Never mind the fact that I'm going to be ordering blood work on you. And typically speaking, LabCorp Quest, you can get those results fairly quickly. Sometimes it takes you a week or two to get an appointment. But we're looking to determine after that surgery, did you find yourself in a deficiency? And the way we follow this is by the blood work and then interpret that and take action as appropriate. Now, you all are sitting at home tonight, and I've just put a slide up that says, what is obesity? And you're going to scan through this, and you may find a couple of points that are triggers for you. You may look at this and think, golly, I'm reading each of those pieces over there, and that may make you feel bad. And I don't do this to make you feel bad. I show you this because this is the disease and the complexity that's associated with that disease. It's not just a matter of, well, I'm on the scales and I don't like the number. Or I put on a pair of pants or a shirt and it doesn't fit like it used to. Numbers, of course, make a difference. But what's more important is to see the improvement that can occur with this successful and appropriate weight loss. We're not just looking to lose weight. We want to lose the correct weight. So obesity, think about this. It's characterized, chronic. It didn't happen yesterday. Most of the people that I see, this has occurred to them over a period of generally 10 years, 15, 20, and sometimes 30. And when that happens, your body's gone through this change, and the characterization of that change that we cannot ignore is we now have excess body fat. When that happens, we begin to see, and it cannot be disputed, we see health conditions emerge that are, quite frankly, they're dangerous. I'll say it again. It's dangerous. There's a lot of causes. Some of this is extremely complex because you go, well, I've had my hormones checked. Well, I've had kids. Well, I've ABC. There can be many causes, including the genetic pieces out there, but a lot of this is going to be behavioral and a lot of this is going to be environmental. If you work at night, if your sleep is degraded, or if you have a job where you are constantly on the run, or if you get up in the morning and you're too busy to get something to eat, you're now at work and then you come home late at night. And I'm just painting some general pictures that we see quite commonly. But there are some behavioral things that we want to discuss. We want to talk about it because in order to have a long-term success, some of these things that you might be engaging in, if we correct those, long-term is going to make you better off. Fourth time I've said it, just in this 1 week alone, 97 lost, 75, 182. So I'll put this question out to my audience. How much do you think you can lose? The challenge has to do with kind of having an appreciation for where do we start? Do I fit into this? Your insurance company is going to have some regulations that dictate who is a candidate for this and who is not. We use the definition piece of obesity with this number that we call the BMI. a body mass index. When I meet you, and when you first come into our office, we're going to put you on a very specialized scale, and it's going to provide some metrics. It's going to be your body composition. It's a sweet rig that we've got. And when you get on the scale, it gives me a printout, and it shows me what your fat percentage is. It'll show the fat mass. It'll even show how much muscle you have. And it'll go through a protocol algorithm and give some computation about how much fat to lose and then what the target weight we would be looking for. Now, class 1, 30 to 34.9. If your BMI is in that class 1, you won't qualify for surgery. If you're in the class 2, and I would suggest write this down. If you're in the class 2, that BMI of a 35 to 39.9, you can qualify, but you have to have a comorbidity. So if you're thinking this moment about your personal health circumstances, those qualifying criteria to begin with: obstructive sleep apnea, diabetes. I didn't say pre-diabetes. I'm talking about diabetes for sure. Then we're going to go to hypertension, and then we look at hyper or high cholesterol. So with a BMI of 35 to 39.9, you must have at least one. And I'm going to have that in a chart. We need to be able to verify that. Now, the class 3 obesity, that's a BMI that's greater than 40. When we get to a BMI that's greater than 40, those comorbidities are not essential for qualifying for gastric surgery. So obesity, I look at a number called a BMI, and at the bottom of this, it's showing what the particulars are. When you come to our office or with your primary care provider who you see, they may have said, well, it just popped in my mind, you want to have a knee replacement. I see this quite frequently. Your BMI is 49. They may not let you have a knee replacement until you have a BMI of a 40. So somewhere in your chart, for many of you, you will know what that BMI happens to be. And we have an excellent staff that can go through the qualifying criteria to help us understand where you fit in with this. So obesity, that's a definition. Let's move on with it again. I see this on a regular basis. In the world that we live in today, fortunately, there's some changes on the perception of this. Now, I think it's important that I'm going to say that if you're engaging in a common sense behavior, so I'm going to put me, for example, I'll put myself under the microscope. Chocolate covered cherries. It's Christmas. I can eat more than one. I can probably eat 2, 3, 4. If you called home and asked my wife, she'd say, oh yeah, I had to go put them away and hide them from you. Now, ladies and gentlemen, there are some habits we know that if we're engaging in those habits, we need to stop. We honestly do. And there was a time when the perception about obesity was that it was a weakness or failure of the individual. The only reason you're heavy is because you won't change your behaviors. Or how about this? Diet and exercise. That's the only way you're ever going to become healthy. Or weight loss surgery. I get this not a lot. I get it from time to time. Weight loss surgery was viewed as dangerous and extreme. And so without trying to get into a contentious circumstance in the exam room, I say, well, when did they have their surgery? Where was it performed? What type of surgery was it? Did they go through a preparation phase? See, we have you go through a preparation. We follow you. We take care of you. We make sure that we give you all of the indoctrination necessary so that you spend one night in the hospital as a rule. You then go home the next day, and then that process of gastric surgery or gastric bypass surgery recovery, you know what to expect. It's not going to be a surprise. Let's take this back up just a moment. The changing perceptions, we see things now. It's being recognized by insurance companies. Obesity is a disease and the cause of many serious health conditions. I want you to take that. You ought to write that down. Put that on the mirror in the bathroom. Obesity is a disease. I didn't say it was a weakness or a failure. I said obesity is a disease and it causes many serious health conditions. And those comorbidities I mentioned a second ago: diabetes, high cholesterol, hypertension, and obstructive sleep apnea. So if you've got the obesity, and here's a point. You might have obesity right now. You may be 31 years of age and you don't have those comorbidities I talked about. Without corrective action, it's not a matter of if, it's a matter of when. And so if we address this now, because surgery is an effective, and by the way, a safe tool. If we address that now, ladies and gentlemen, then you get to be my age and you've maintained your independence. You're happy. You then get into what I refer to as the terminal or the marginal decade. You can look that up on the internet. What we do today is laying the framework for how your house and foundation are going to be standing in these years to come. So the perception of obesity used to be, well, don't worry about that. We now look at the way that this is, and the insurance companies will respect this. Before I flip the slide, I want to raise a question about something, and that's this. Insurance companies, generally speaking, do not cover weight loss medications, but they will cover gastric surgery. And you ask yourself, why? Why won't you give me an injection as opposed to I've got to go do surgery? And the answer is quite simple. It's because the surgery works. And we see overwhelming success long-term. And I've been in May, I would have been here 10 years. If I did rough numbers, counting the repeat people that have come back, probably 11,000 interactions with people. I always see greater success with the surgery than any of the other processes that we have to offer to you. I bet you've never thought of central obesity in this fashion. It's one thing, you go to the emergency room, well, I twisted my ankle, or I broke my arm, or you name it. I cut myself shucking oysters this week. Those things sometimes are rather clear cut because you go to the emergency room or your primary and you go, you got a headache? Here, take an aspirin. Obesity, my friends, this is a gland, and you need to think of this as a gland. It takes on its entire, it's its own environment. It is an endocrine gland. It's the largest gland in your body. And here, I'm not making this up. It secretes hormones. Did you hear me? That gland is producing hormones that can cause, look at there, heart attack, stroke, diabetes, joint pain, and more inflammation. Got a number of people that come in with rheumatological disorders. They've got lupus, psoriasis, golly, rheumatological arthritis, fibromyalgia, depression, a lot of things that are extremely, let's throw another pill at it. Let's see if that injection will work. It's safe to say, folks, that if we can work, you, me, our team, and your surgeon does the state-of-the-art, I'm talking state-of-the-art surgery. He's going to talk about that in a minute, but a state-of-the-art procedure, and then you get with us and we teach you these things, we mold that, we begin to help you understand that central obesity, we get rid of that or a huge portion of it, a lot of these problems are probably either going to go away completely or they'll become so manageable that you'll see more smiles than you will frowns on your face. So, the choice is yours. I've got 1, 2, 3, 4 people that have lost a tremendous amount of weight, and that's just in this 1 week. Now, I've been working on a car in my garage for the last couple of weeks. The windshield was broken. Anyhow, I listen to music when I'm out there repairing this thing. And I got this song, and it's Conway Twitty and Loretta Lynn, And the name of the song is You're the Reason Our Kids Are Ugly. Genetic makeup, including family history, can be a huge determining factor of what that path for you might, I said might be. I correlate or metaphorically say that genetics are equivalent to putting a gun in the chamber of my rifle or my pistol. But it's my behavior that pulled the trigger. So yes, mom and dad may have that, might even have skipped a generation, but it can play a role. But you can't pick your parents. I can say, well, pick your parents up and give them a hard time about it. Well, no, that's not going to work. How about ethnicity? No denying that. No denying that. Especially if you grow up and the ethnicity of where you originally come from consists of a big family and food that's love. Oh, I love you so much. I want you to have another helping of whatever. Medical causes, diseases. Oh, yeah. Certain medications I know for a fact will cause weight gain. Just think this one thing. Insulin. Get on insulin. You have a hard time losing weight. There's also a medication for young gals some years ago called Depo-Provera. Take Depo-Provera, see what happens. Hormones change. Ladies, premenopausal, postmenopausal. What about the young gal that has a hysterectomy in her 30s? Stress. Cortisol. The moment you are under stress, it immediately makes it difficult for you to lose weight. These are the facts. And you hear me say it, and it should be a relief to you because we know this. I'm not going to look at this and say, oh, okay, stop that, start doing this and have 100 pounds weight come off. Folks, that's why you're here tonight. You've tried that. And you know, as I'm reading from my list, this is what we have going on. Lack of physical activity. If you've got a BMI of a 41, 2, 3, 4, 5, and you're trying to get knee replacement, how much physical activity should I expect that you could do? I've got to be reasonable. Okay. Environment. That's a big one. Between the hospital and my house, there's no less probably than 20 places I can pull through the drive-through and I can get something to eat. And I've wised up because I know that if I pay cash, my wife won't see what I used on my debit card. Medications. So a lot of factors out there, guys. A lot of factors. You come and you're looking at, I can't change this. This is where I am. One final comment before I move to the next presentation of the slide here. I want you to think about a concept called metabolic memory. And I asked my listening audience tonight, hey, how much is 6 times 6? Everybody goes, that's 36. When did you learn that? You learned that probably in elementary school, 3rd grade maybe. If your body, if your brain has the structure and the complex relationships between cognitive function that you could remember something that you learned in the 3rd grade, is it possible that your body has now learned and adapted to a very high BMI? And it has a set point and it does not want to give that weight up. You go, well, I'm not eating this. My weight didn't fall. I'm doing everything you said. I've done it 30 days and the weight still didn't come off. That's why you're here tonight. And that's why you could probably be one of these people that have had such fantastic success. Look at this list. Some of these can be kind of scary. Cardiovascular disease. I think in this country, you could Google it while we're sitting there. You know, somebody say, hey, how many people are going to die within the next 60 seconds of coronary artery disease in this country? And the number's incredible. Polycystic ovarian syndrome. Yeah, I hear about that every day. Vitamin deficiencies. I'm not going to go through each of these pieces, but scan that while you're there at home and say, hey, yeah, I've got that, and that. How does that affect me? What is that doing? I've got a daughter that's going to graduate high school this year. She's 18. Maybe she's going to college. Maybe she's got the love of her life. Maybe they have kids. I want to be around to play with my grandkids. I want to be around to see them get married. Well, what if you had the opportunity to get on the phone in the morning or talk to Angie tonight and say, you know what? Sold. I want to go have the conversation with the surgeon about this because I have all of these over here and I can see how these have threatened the happiness that I have, the things that I hope to do, because surgery is that presentation that can either make these go away completely or certainly put them in remission. Surgery is I was watching this was a movie, I think around Thanksgiving, and I'm a car guy. And it was the business between Ferrari and Lamborghini, and they were at a car show. And Ferrari was dominating the sports car, exotic car community, and Lamborghini was trying to break into it. Well, the Lamborghini guy is in the showroom, and the Ferrari guy's over there watching him. And the Lamborghini guy says to the press, "Hey, if you want to be somebody, you buy Ferrari. But once you are somebody, you buy Lamborghini." Point I want to make with this, we've got a Lamborghini here. All right. Trivial point. I know this isn't going to keep you awake tonight, but it's interesting to see there that just within the last coming up on 3 years, almost half of the country is suffering from this. The numbers that's incredible. And the impact that has, it's quite far reaching. 100 million adults. Big number. Getting close to the end of my presentation, y'all. When you come and you see me, or Brandy up front, or whether you might even see Courtney, Megan, Dr. Parker, Dr. Jarrard, it depends. Our goal, our teamwork approach here at TMH, you're in that box over there with the obesity piece. 3 things we're going to go after, and I'm going to get my money's worth, I promise you. I want your health improved. I want your quality of life better. And body weight and composition. Those 3 pieces are intertwined. They wrap around each other. And that's our goal here. I think it's important to take a look at this. Is the in vogue, sexy way of doing things these days. At least there's a perception about this. And I get to comment on it because I've been sitting in the seat doing this for some time, and I've seen the generation of the GLP-1s come along. And I can, without reading magazine sources, I can tell you what my witness to it has been. So let's walk through these just a little bit at a time. Now, you might even be on a GLP-1 right now for weight loss. You might be on the GLP-1 because of obstructive sleep apnea, and you may be even one of those that would be on it because of type 2 diabetes. Side effects, and I'm not going to take a rope and try to lasso this thing and brand it and say, don't do this. That's not my point. But I think it's extremely important because these questions can come up about the effectiveness and the results. So let's take a look at this. The side effects. I see this every time. Nausea, vomiting, diarrhea, constipation, fatigue. Sometimes a person has it worse than someone else. But everybody in these initiation low doses during the titration phase to this, they get to go through that nausea, vomiting piece. Side effect. Gallbladder disease, not seen that. I have seen pancreatitis, and I think, one person in this past week or 2, I heard them mention something about their visual changes were there. Now, here's the next part. 70%, up to 70% of these people, they stopped using GLP-1. GLP-1, glucagon-like peptide-1, equivalent to the drug Ozempic, Wegovy, Zepbound, and Mounjaro. And Wegovy just had their pill go live this week. 70% of people using these, they stop them within 12 months because of not achieving their results, or they were having unwanted side effects. I think it's extremely important to say with this. When you use a drug like this, and it's mandatory, if I'm going to prescribe it, you have to let me do a body composition. I need to see your labs. You must see a dietitian, and then we follow it. We don't just Amazon deliver this to my house before noon tomorrow. It doesn't work that way because there is a risk associated with these. And the standard of care is we treat, we follow up, we treat, we follow up, we adjust appropriately. Now, this is a great big point, and Dr. Jarrard's going to talk about what his surgical results are going to be in a moment. But I want to take a couple seconds with you on this one. The weight loss medication, those folks that are using those, 5 to 15% body weight loss. Now that's better than nothing, of course. When you get into the range of gastric surgery, be it a sleeve gastrectomy or a gastric bypass, we do some. I want to just go ahead and let me just go ahead and say this. You can find that your excess weight can be reduced by 70%. I didn't stutter. 70%. So what that tells you, if you're 100 pounds overweight with a GLP-1, we're lucky if we might get 20 pounds off. But with the gastric surgery, I'm looking at getting 70. And because of our program, we're going to help you face and focus the kinds of behavioral changes that I need you to do. I need you to be engaged. My rules, you do your best, you don't quit, and you maintain a journal so we can see what the behaviors are. And oh, by the way, there's the money thing. This stuff's extremely expensive. Now I'm about to switch over here to where Dr. Jarrard's going to come in here and go with this one. But I want to say this. This is important because I get to see this. I get to come to work, and this is not a Hallmark moment, so it's not fluffity stuff here. I'm not that kind of guy. But do you know what it means for me? And I'm not the guy doing it. Do you know what it means when someone comes in and says, I can bend over and tie my shoes? I can go up the stairs because I'm not short of breath. I was able to get on an airplane and go see my brother before he passed away. Surgery is one heck of an effective way to lose weight. And like I said now, probably third time, the high blood pressure, the cholesterol, the diabetes, the sleep apnea, the emotional upset either goes away completely or it's almost gone. And we're getting rid of 70%. You come and see me within the first 5 minutes, I'm going to tell you, here's what I think is going to happen. This is an exciting evening for you guys. If you're on the edge of making this happen, you're in the right place. Okay. Now, one more slide here, and we're going to turn it over to Dr. Jarrard. Are you a candidate? When we get done tonight, you're going to have the opportunity to talk again with Angie. We're going to have a question and answer session back and forth. Are you a candidate? Great big question. Got a BMI of 35 with comorbidities, high cholesterol, diabetes, hypertension, sleep apnea. You got one of those? You don't have to have 4. I need 1. If you're healthy enough to undergo a major operation, and before you go, oh, I don't think so. I had a young lady, 82 years of age, with a couple of things. We got the clearances. She's on a cruise ship right now. Absence of drug or alcohol problems. Okay. No uncontrolled psychological circumstances. And by the way, we're going to walk you through the evaluation process so that we can address these things, get you the help that you need, and then proceed. We got a team that's going to look at it. All right. This has been kind of fun. I could sit here and talk about this all night, but Dr. Jarrard, I'm sure, got better things to do. So without further ado, I'm going to turn it over to him. You guys have a great evening. I'll sit back and wait in case questions are out. Night.
All right. I think I got it going. Can you hear me okay? Greg, Angie, can you hear me?
We can hear you.
Okay, thanks. Um, Let me see. There we go. Got it all going now. Um, all right. Well, thanks everyone for joining us. I'll be brief. I kind of want to go through this fairly quickly, a 1,000-foot view. We can certainly talk about any and all of this during the Q&A period afterwards, or if I get to see you in my office, happy to discuss any of this in more detail. So in general, we offer three different types of bariatric procedures at Tallahassee Memorial. The lap band is not offered. That is outdated, probably over 10 years ago and should not be done. The gastric sleeve, vertical sleeve gastrectomy, multiple names for it, is a sleeve for short. Definitely the most popular. That's about 70% of all procedures done nationwide now. Do lots of sleeves. And then malabsorptive procedures, the duodenal switch and the gastric bypass. So the gastric bypass is number two, probably 20 to 25% of what we do. And then we do duodenal switch very selectively. Um, Talk a little about each of these. Starting with the gastric bypass, you can see a normal anatomy on the left, but on the right, we've divided the stomach into a small little pouch, and then we brought a piece of intestine up and sutured it to that pouch. So when you eat, instead of being able to fill up a large stomach, you fill up a very, very small stomach. So you feel full very quickly. Once you're full, though, it starts emptying fairly quickly. So you're going to feel full much faster, but you're going to eat multiple small meals throughout the day versus two or three very large meals. The first part of it is you are eating less, you're taking in fewer calories, and then by suturing the small intestine up to the stomach, we're bypassing that first portion of intestine called the duodenal suite. That's where a lot of your gastrointestinal hormones take place. Insulin gets stimulated to be released. So by bypassing that, there's a malabsorptive component. So you are not absorbing or taking in 100% of the calories that you do eat. So there's a malabsorptive component. The sleeve, very, very simple. Nothing is rerouted, nothing has changed. We're making the stomach smaller. So we take a thumb-sized tube, anesthesia puts it down your mouth and into your stomach, and then I just fire a surgical stapler along that tube. So you can see you go from having a stomach shaped like a purse to a stomach that looks more like a banana, very small. Nothing is rerouted. There's not really a malabsorptive component to this. You just eat fewer calories, tend to be full longer, and that part of that is due to a decrease in ghrelin, which is your hunger hormone. Duodenal switch is a lot more involved, and I'm happy to describe this in detail in the clinic if you're interested in this or want to discuss it further. But it's kind of a combination of a sleeve and a malabsorptive operation. So the first part of it actually is a sleeve gastrectomy. You can see the stomach is shaped like a banana, like as in a sleeve. The malabsorptive component comes in that we divide the intestine just past the stomach and reroute things, similar to a Roux-en-Y. This is far more malabsorptive than a Roux-en-Y gastric bypass. This is pound for pound the most effective weight loss surgery. However, it's a double-edged sword. Typically, the more effective or more aggressive a weight loss procedure, the higher the risk profile. So vitamin deficiencies, diarrhea, things like that are far more common with a duodenal switch, but there are reasons or times that you would choose this over other procedures. Complication risk for bariatric surgery, anybody who comes to our office will get a risk calculator with their specific info. So based off of your age, your sex, your ethnicity, any medical problems you have, we're able to put that into a risk calculator and give you specific numbers for your risk of complications. But in general, reflux occurs in about 10% of patients who get a sleeve gastrectomy. For a gastric bypass, however, that is an anti-reflux operation. So I will often choose a gastric bypass in patients who already have reflux just to prevent that from getting worse, and it actually treats the reflux. So gastric bypass is an excellent weight loss procedure if you have acid reflux. Atelectasis is just a fancy word for you get a little fluid in your lungs after surgery. That's just from anesthesia. That's just from not taking very big breaths early on. And that is very, very rarely an actual complication. It's just it can delay your recovery if you're not focusing on big breathing afterwards. And that happens with any surgery. That's not specific to bariatric surgery. Wound infections are pretty rare. Marginal ulcers and these other complications you can all see are in the 1% or less range. A marginal ulcer, just briefly, is specific to a gastric bypass. What that is an ulcer that forms at the connection from the intestine to the stomach. That is very specific to a bypass because, again, we're not making any connections or changing anything with the sleeve. But again, those are rare. Those are almost always associated with nicotine or NSAIDs or steroids. So if you take ibuprofen, Aleve, Advil, Motrin, Goody Powder, Voltaren, naproxen, or steroids, you will probably get an ulcer after a gastric bypass. So we're very insistent on avoiding those things. What are the major complications? So a stricture is a narrowing. It's a fancy word for a narrowing where things don't pass by very easily. So a stricture at your connection with a gastric bypass or a stricture in the stomach from the sleeve, very rare complications. Hemorrhage is bleeding. So bleeding occurs in 1% of patients. Anastomotic leak, that number is lower than that, I believe. In general, anastomotic leak or a leak at the actual connection is going to be a complication mostly associated with revisions. So someone who's had a sleeve or a lap band that eroded into their stomach and we're having to remove that and convert to something else, or someone who's had multiple surgeries, complication rates are a little bit higher, so leak rates are a little bit higher. Knock on wood, I have never seen a sleeve leak, and I've done at least 5 or 600. So the numbers are low. Small bowel obstructions, that's just a kink where you get nausea and vomiting and things don't pass. Very rare. Risk of death, very, very low. So here's our specific numbers with sleeve, just our previous year. Our readmission rate was about 3%, and that is almost always related to dehydration or not being able to keep up with with caloric requirements. That's not always easy early on. And anybody who says that bariatric surgery is the easy way out or cheating, let them get through the first few weeks of bariatric surgery. It's not always very easy, but it is worth it. I've had very, very, very few patients who regretted their decisions, only one or two. It is very rare. The vast majority of patients have success with this. And even though the first week or two can be a little tough, they're very, very happy afterwards. 0% risk of most of these complications that we just discussed compared to the national average on the column on the right. What are the long-term complications? So it would be foolish of me to try and convince you that surgery is perfect and that it works every time and that is completely risk-free. It's just simply not the truth. It works in a majority of the time, and it is very effective most of the time. And few patients have complications. But it is possible. And what are those complications and how do they happen and what do we do about them? The good news is here, we're not a bariatric factory. We're not a sleeve shop. Unfortunately, lots of those exist where a surgeon or their partner with no specific training in this specialty will offer lap bands or they'll offer a sleeve gastrectomy. And you'll notice if you talk to patients who go through this, there's very little education up front on what they're supposed to be doing before surgery, and even less education on what they do after surgery. I've seen patients go to other countries because it's cheaper for bariatric surgery, and they come back with zero information about what they're supposed to be doing, how much they're supposed to be drinking, how much protein they're supposed to have, how many calories they're supposed to have. And patients really, really get in trouble with that. We pride ourselves on being a multidisciplinary, comprehensive program that we attack from all odds. So when we do see these complications, and a vast majority of the time, it's from outside. Uh, the ones that we discussed earlier are related to surgery. These are just long-term complications related to the fact that you have had bariatric surgery. What are those? Protein malnutrition. This is not uncommon because most patients don't get in enough protein. Most American adults don't get in enough protein, and you should be getting in probably a gram of protein per kilogram of body weight at least. So that is a lot. So if you weigh 220 pounds, you should be getting 100 grams of protein. That's simple math. Dietitians may think that you should need more, and they probably do recommend more. If you have surgery, you need even more protein. So that's why we talk about protein shakes. There's no way to eat enough protein before or after bariatric surgery to meet your requirements. So you do have to rely on protein shakes, and you get sick of them. We recommend different types. I've had patients get fancy and cook them and sugar-free brownies. I've had them freeze them at popsicles. I've had patients make jello out of them just because they get sick of the texture. It's a real thing, and you can get sick of protein shakes around surgery time, but you'll love them lifelong. If you're not doing that, or if you do well from surgery, you're a year or two out from surgery, and you say, okay, I did great, I met my goals, I'm going to go back to the way I was living and completely disregard what I'm supposed to be doing. Those are the patients who get in trouble. Those are the patients who are years out from their bariatric surgery, hasn't seen a dietitian, hasn't seen a bariatrician, they're not taking your multivitamins. Those are the patients we see that get in trouble. The patients who are compliant, that we see them every 3 months, 6 months, every year, like we're supposed to. We're checking labs. They take their vitamins. Protein nutrition and vitamin deficiencies are extremely rare in that population. I'm not saying it's always the patient's fault. I'm not saying it's anybody's fault in particular. What I am saying, though, is these are preventable. How much weight would you expect to lose? Now, you'll see if you come to our office, you'll get a risk calculator. You'll also get an anticipated weight loss curve based off of thousands and tens of thousands of people across the country who are of your age, sex, race, comorbidities, etc. So we match you along with how the average patient nationally did in your category. And on average, this is about 40% excess weight loss in the first few months. And you can see at 6 months and 12 months that slows. That is a very common question I get. Am I going to waste away into nothing? No. Most of your weight loss happens up front in the first 3 to 6 months, typically slows significantly by 9 months. And it's pretty rare to continue to lose weight after 1 year. So it's all mostly in the first year. And after that, it'll slowly even out. Some patients gain 5 to 10% of that weight back after the first year, and then maintain that, and then that's okay too. But that's how the weight loss curve goes. There's very similar weight loss between the sleeve and the gastric bypass. I have patients all the time who said, "Well, I want to lose more weight, so give me a bypass." It's not quite that simple. There's a lot that goes into that. By far, the biggest decision factor that leads to one or the other, or is reflux, which I alluded to earlier. If you already have acid reflux, a big hiatal hernia, you have strictures and that have to be dilated or stretched, you should not get a sleeve gastrectomy. And I'm not saying that you shouldn't get one from me. You shouldn't go somewhere else just because I recommend a gastric bypass. I think going somewhere else to get the answer you want is probably not wise. And I would much prefer you go somewhere else and get a gastric bypass than get frustrated at my recommendations. But if you have bad reflux, please do not get a sleeve. You will regret it, and you will ultimately probably have to be converted from a sleeve to a bypass. Now, it is possible 40 or 50% of patients with mild reflux will actually have some improvement after a sleeve, but that's a minority. The most, if you already have significant reflux, that could get worse. So it's worth a conversation at least, and I'm happy to just dive in that a little bit further, either in the Q&A or in my office. But reflux is the single most important factor when choosing the operation. Greg just discussed this at length. I don't think I'm going to do a better job than what he did. But I think the point here is the scale, your weight is not the only measure of success, nor is it even remotely the most important measure of success, the weight, the percentage weight loss. How do you feel? How do you feel? Are you more mobile? Are you achieving your goals in life now? Is your quality of life better? Are you able to participate in family and friend events that you weren't able to earlier? You're going to live longer. So it's not just the weight. The average patient gains about 9 years of life expectancy after bariatric surgery. That's almost a decade. So you have a longer life. You have a 50% less chance of dying of cardiovascular disease. You have a 60% less chance of developing most types of cancer. You have significant improvement of your fertility if you've struggled that for a while. So think about all those things: cancer, having a baby, living longer. And you tell me that weight is still the most important factor. It's not. So keep in mind that this is big picture. This is prolonging your life and helping to have a better quality of life. Um, the effects that weight loss surgery have on your body are it's extreme. It's every organ system is affected by this. We talked about cancer, infertility, your liver, fatty liver disease. That's becoming rapidly the number one cause of liver disease in the country, whereas alcohol and hepatitis used to be. It's just fatty liver disease now. And bariatric surgery has been shown to reverse fibrosis, which is profound. High blood pressure, high cholesterol, diabetes. It helps with all of these things. And then again, a whole list of things that you wouldn't think about. We've discussed most of this already in my rambling. Very briefly, how do we do it here at TMH? They're all done robotically. We were doing some laparoscopically, but there's been basically 100% shift to robotic. I've seen less pain. I've seen less nausea. My ability to do more difficult surgeries in patients who even at the extreme weights. I've been able to do this robotically without any difficulty, whereas those patients were typically deemed not surgical candidates. So I think it helps reduce pain and nausea, but has really extended what I'm able to offer here at TMH. All of our surgeries are done. Typically, sleeves are 30 to 45 minutes. Gastric bypass is usually an hour and 15. We may or may not have to fix a hiatal hernia at the time of surgery. That can add a little bit of time. But generally, under 2 hours, you're getting an operation with four small incisions, and most of our patients go home the day after surgery. Um, Everybody stays one night in our program. I think it's just a safe way to go for most patients. We're really there to make sure that you get up and move and that you're able to tolerate your liquids. We don't want people having to come back to the ER or coming back for additional IV fluids when we can keep you in the hospital for 12 hours, make sure you're drinking 3 or 4 ounces. Do a quick educational recap. Angie's great at that. Just reminds patients all the stuff you learn while you're in our program before surgery. How many calories am I supposed to take? What is my diet again? Who do I call if I have issues? Go over all that extensively before you go home. And I think that's just a well packaged plan to keep you from having to come back. Insurance information, we discussed this briefly. In general, if your body mass index is over 40, you're a candidate. That does not mean that your insurance covers it. And that's the bane of our existence. It is the most frustrating thing. And it is one of the more painful things to try and navigate. Does my insurance cover this? And Angie can provide additional information to help you determine sort of how we figure this out. In general, Medicare, Medicaid does, Aetna, Cigna, most of those do. CHP is a little tricky. Blue Cross Blue Shield is a little tricky. There's a lot of subsets of plans that we may have to help you navigate to determine if you have bariatric coverage. But if your insurance does allow for bariatric coverage, if your body mass is over 40, you'll qualify. If you have diabetes or high blood pressure or any medical problems associated with your weight, that cutoff goes down to 35. So it's a little bit more lenient with a lower BMI. As long as you have medical problems associated with your weight, you would qualify for surgery. If you don't make those qualifications, you may still qualify for non-surgical options as a part of our program. So we're happy to discuss any of this further with you. That's kind of out of the scope of today's talk. That's all I have. I wanted to allow for plenty of time for Q&A, and I'll just kind of open it up for questions. Anybody got anything?
Here we go. What are the options when insurance has excluded surgery?
That's a tough one. Get a new insurance, right? I mean, it's easier said than done. Um, Unfortunately, if your plan has a specific exclusion, it says in the wording, we do not cover bariatric surgery. I'm just going to save you a lot of time and agony. I can't do an appeal. I can't write a letter. They have an exclusion. There's nothing I can do. My hands are tied. We have developed a cash pay option that we can discuss, kind of give you some specific numbers. I've tried my best to consolidate this into a one single payment deal, whereas it used to be fairly difficult to navigate what are the office fees for the dietitian, the surgeon, the bariatrician, the pathology fee, the inpatient hospital fee, the surgical fee, the anesthesia fee. And we've consolidated all that into one specific payment option, which makes it much better. So there are options, even if your bariatric or if your insurance doesn't require or cover bariatric services. There are options, but we'd have to discuss that on an individual basis.
All right. Are you able to return to work within a couple of days?
No, please don't return within a couple of days unless you work from home and you're your own boss. Um, we have done away with narcotics, which is a big victory in our program. Patients don't need narcotics. They don't. They just don't. We do nerve blocks. We do multimodal stuff. Patients don't need narcotics. I think that significantly increases your recovery. We have noticed a significant decrease in the number of ER visits, the number of readmissions, and nobody ever calls and asks for additional pain medication other than we can do muscle relaxer or Tylenol. I know that, let me digress. Since we've eliminated narcotics, patients get up and function a little faster. And again, it's a testament that you don't need narcotics, that you're up and functioning much faster. That being said, you can't overdo it. You did just have a big surgery. It's going to take a couple of weeks to recover. And the number one problem I see patients have that do return to work too quickly is that they haven't gotten used to that diet yet. They haven't gotten used to that constant sipping of water throughout the day. And you go back to work too soon, you get distracted, you get busy, and before you know it, you've gone all day without drinking or having protein, and then you're behind and it's hard to catch up. So I'm a big fan of, taking a couple of weeks, really get into the swing of things, get compliant with your diet, get used to drinking, staying hydrated, and then return to work. Do it safely.
We got lots of good questions. Do these surgeries have side effects like the GLP-1s over time?
We've talked about the long-term stuff. So the GLP-1s work on a hormonal level and they block certain hormones and dysregulate how your physiology works. Meaning they slow everything down. It slows your stomach down, right? It makes you feel full all the time. That's how they work. Reflux gets worse. It also slows down your colon, constipation worse. Slows down your pancreas, pancreatitis, slows down your gallbladder. I've seen patients come in with gallbladder infections and they don't even have gallstones. I've never heard of that before until of GLP-1s, and I see it. So that's how those things work by affecting your entire body physiology. For the most part, the sleeve, you eat less. Very simple. There's a reduction in some of the hunger hormone. I won't say that that's the only reason you would eat, right? But it reduces the amount that you're taking in calorically. There are much fewer systemic or body-wide effects compared to medication. So sleeve, you eat less. You have a higher risk of getting some reflux. Gastric bypass, higher risk of certain vitamin deficiencies and things like that. It does not affect your thyroid. So if you have a history of medullary thyroid cancer, you can't take GLP-1s. Doesn't matter with surgery. Um, and all the other things regarding your gut hormones and the effectiveness of your intestines and your gallbladder, those are not affected on a body-wide level like patients who take GLP-1s are.
All right. I can take the next one. Does the CHP plan offered by TMH cover the surgery? The answer to that is yes. There is an additional deductible for bariatric surgery, but I'd be happy to discuss that with you and go over your plan specifically if you want to give me a call at 850-431-4046. Next, it says, can I still be a potential candidate for sleeve if I have mild acid reflux, which is totally treated by meds?
Yes, and that's something I'm happy to discuss in more detail. In general, if you have very mild reflux controlled with medications and you don't have any abnormalities in your esophagus related to your reflux on an X-ray or EGD, and we can talk about that. then in general, yes, a sleeve is still an option for you. If it is not controlled on medications, or even if it is controlled, but you have ulcers, you have irritation, you have problems in your esophagus related to your reflux, that's where we draw the line and say sleeve's just a bad idea. So yes, the answer is yes to your question.
All right. Being a woman, how long do you have to wait if you want to start a family? Do you want me to answer it?
If anybody else is answering the question. Um, So in general, we say a minimum of 1 year, but preferably you wait a couple of years. You completely recover from the surgery, you rebound, you're not actively losing weight. You're established with stable calorie intake, stable vitamin intake. So generally, that's the safer option. What are we officially saying now? Is it 18 months?
In our discharge, we have 12 to 18 months.
Yeah, it's at 12 is an absolute minimum. And the reason I say that is the chart that I showed you earlier is you're still losing weight up to a year. And you don't want to be actively losing weight and growing a fetus at the same time because a lot of the nutrients that your body's trying to hold on to will be withheld from the baby. So you don't want to actively lose weight and try to grow a fetus. You want to wait until you're completely stabilized and on a good, stable pattern. And that's why we say 12 is a bare minimum. 18 is much safer. And if you want to be very, very conservative, up to 2 years. But I think 18 months is a safe answer.
Right. Is it required or needed to have someone assist you post-surgery?
Um, Define assist, right? I'm very, very big on you getting out of bed. I'm mean about it. And you can ask if you have friends or family members who've been my patient already. You're out of bed. The afternoon of your surgery, you better be walking the halls. If I happen to catch you in the morning and the lights are still turned off, they're coming on. I'm turning the lights on, I'm turning the blinds on. And if I come back a second time and you're still in bed, you lose your bed. I have nurses pull the bed out of the room. We walk, we get up and we move because the number one cause of death after bariatric surgery, blood clots, right? So we can't be stationary after bariatric surgery. So I want you up and active and moving before you leave the hospital. So if you're doing that before you leave the hospital, you can cook for yourself, you can clean for yourself, you can go to the bathroom yourself. You should not need help doing those things. However, having a coach at home, having a support at home goes a long way. Hey, have you drank this hour? Hey, are you eating enough? Hey, are you doing what you're supposed to? Or hey, you fell asleep on the couch for an hour. Let's get up and move. Let's get up and drink. So having a coach is great. But as far as having a lot of physical assistance, it's not needed now.
Does the CHP state plan generally cover it? As long as you are a surgical candidate, they do have coverage. And once you get in for your first consult, how long does the process generally take until surgery has been approved and completed?
That is insurance specific. I would set the expectation that regardless of your insurance, 3 months is kind of a bare minimum. I would say 4 months or so is probably our average. But some insurances do require monthly visits for 6 months and a few extra hoops for you to jump through in order to get approved. So that's not us making a standard mandate that everybody has to go through 6 months. We don't do that. I would say three is a minimum. And six is generally the maximum that we see of insurance requirements.
How long after surgery would you have to worry about getting blood clots, and is this something that could be easily resolved?
That's a tough one. It depends on your overall risk factors for blood clots, right? So, what is your age? What is your weight and BMI? Do you have a history of blood clots? Do family members have a history of blood clots? Do you have atrial fibrillation or AFib? So, there's a lot of risk factors that go into your overall what is your risk of getting a blood clot. So, patients who are very high risk, um, we keep on blood thinners after surgery temporarily. Depending on the risk factors, it's generally either 2 weeks or a month. That's for our high risk patients only. Everybody else gets a single dose of blood thinner right before surgery. And then when you're in the hospital, we typically keep you on an injectable blood thinner. until you go home. If you're ambulating or walking, like everybody has to do, by the time you leave the hospital and you promise you're going to do it when you get home, your overall risk of getting a blood clot if you're up and walking and moving and you're low risk is very, very low. Um, they're not impossible. We see a couple a year. We're in that like 0.5% ish range, where we'll see someone get a blood clot in their leg or arm. Extremely rare for those blood clots to move to the lung, but that is the risk that we get concerned about. So anybody who gets that, everyone's educated. If you have one leg swelling or one arm swelling, we like to know about it. If we identify those things, we typically get an ultrasound. You get started on blood thinners, and then it kind of goes away on its own. So that's most patients.
All right. If you have an identified small hernia that doesn't cause any problems, is that still generally remediated during the surgery?
So hiatal hernias, yes. In general, if we're doing a bypass, it's usually for reflux, so we want to fix the hiatal hernia at the same time. If you have mild reflux and you want a sleeve, we definitely want to look out for hiatal hernias and fix those because that'll increase your risk of having reflux after a sleeve. So a hiatal hernia, yes, we generally search for those and fix those at the time of surgery. Other types of hernia, though, abdominal wall hernias, umbilical hernias, inguinal or groin hernias, we do not repair those at the same time of surgery because we typically would want to use mesh to fix those types of hernias, and we don't use mesh at the time of a gastric surgery.
How long is the downtime before going back to work? I sit down about 80%.
I think we've covered that one.
All right. I think that's all the questions. We had a lot of thank you so much. This was excellent and informative. Thank you guys for joining. Dr. Jarrard, do you mind advancing to the next slide that has my phone number and email?
I think I stopped sharing.
Oh, that's Greg's. Here,
I can try to share again.
I'll also send a follow-up email. So everyone, if you'll just be on the lookout for an email. Also, that's how I'll be letting you know if you won the Publix gift card. Please, there it is. Thank you, Dr. Jarrard. Please feel free to email me or give me a call if you'd like to set up a consult or if you have further questions. I'm happy to get those answered for you or set you up with an appointment. We appreciate you joining us tonight. Thank you all so much.
Thank you, guys.